Okay, it's looking like traffic is slowing down. We will continue to admit people from the waiting room, but I think we have critical mass to get started. Thank you to those who were here promptly at 11. We greatly appreciate it because we have a packed agenda for you each session of our reading course. You are here for the first kickoff session, which is co-led by myself and my wonderful colleague and friend, Dr. Corey Bradley. We are going to be talking about shifting your focus and an introduction to dissemination and implementation science. To give you the lay of the land, every time you come to the implementation science reading course, you will spend about half of your time hearing a didactic about a key foundational implementation science topic, and then the latter half will be spent with a small group leader and team of other colleagues for intense collaboration and discussion. The first week, we tend to take about 35 to 40 minutes in this didactic portion because we also want to do a little bit of housekeeping. So just be aware that you will have a slightly shorter abbreviated discussion time today. All right, so to give you the lay of the land, what I hope to cover today with Dr. Bradley is first, we want to thank a number of key players without whom this course would not be possible. Then we'll spend about 10 minutes talking about course logistics so that you know exactly what to expect each session. And then we'll really get into about a 20-minute introduction to implementation science, and we'll close with some additional resources. And we hope finally that you'll have about 20 minutes with your small discussion group today. First, we could not have this course without the small village that it takes. As you can see, we have about 100 people signed up for this course, and this is a critical free resource that we offer to the Northwestern community each year. Each year, we consistently have about 100 people sign up, and we can only serve that many people with an enormous amount of people volunteering their time. So I want to thank all of the people on the screen who have volunteered their time either as a small group leader or as a lecturer for this course. If you look closely, you'll notice a number of names are in purple font. Those are folks that are volunteering with us for the first time this year. And so we especially want to thank them for joining our implementation science educational community and helping to make this group possible. We so appreciate each and every person on this slide. There are three women in particular that I also have to publicly shout out. Dr. Sarah Helseth serves as our faculty lead on the implementation science reading course and has done an enormous amount of coordination work. And then Emma Little and Jordan Viernes really make the magic happen in this course. They do all of the heavy lifting, organizing SharePoint, making sure you have your resources each and every session. And they also make all the magic happen on Zoom. And we are completely indebted to them for their incredible organizational skills on making this group happen. So thank you so much to these three women. We also want to thank NewCats, Dissemination and Implementation Science Program, which helps to fund this reading course and make it available for free. And then we also want to thank the Prevention Science Methodology Group that first kicked off this group about 7 years ago. Our goal with this free course is to help you to achieve a set of beginner level implementation science research competencies. Each session will cover some different competencies, and we'll at each session tell you the ones that we are really focusing on that day. Today we have some broad goals, but we're going to give you some background information on implementation science and research terminology. We'll define what is and is not implementation research. We will differentiate between implementation research and other related areas. We'll give you a little bit of information about the potential impact of disseminating, implementing, and sustaining effective interventions. And we hope to really convince you that a range of expertise is needed. And then we will also spend some time exploring opportunities for defining and operationalizing health equity in implementation research. Now let's take about 5 to 10 minutes to really talk about course logistics. There are three main things we want to emphasize. Each session, we ask you to do a set of readings. We will give you a didactic presentation, and then we will have group discussion. For the readings, we try to make it manageable. We really could assign you an enormous set of readings for each session, but we've really tried to distill it to 2 to 3 classic, widely cited implementation science articles that if you are to submit a grant, these are articles that reviewers would be likely to recognize and are some of the most well-cited articles in the field. We also recommend 1 to 3 supplemental articles that we think really help to reinforce the concepts. You do not have to read those, but we highly recommend that you do. And then finally, we, throughout each session of the course, will use a case example to bring these skills to life. And when there are publications showing that case example, we denote those by asterisk and encourage you to read that as well so you can see the principles in action. For the didactic presentations, these will be co-led by Northwestern faculty, all volunteering their time and effort. They will be about 30 minutes in length, and we will talk about basic practical methods that you can use across settings, populations, and disease states. And we make these slides available to you, so you do not need to take copious notes. They'll be on our SharePoint within a week. And then group discussion. We really took a lot of time trying to assign you to small groups based on your interests that you filled out in the registration form. You will be assigned a small group leader, and we will ask you to please volunteer to serve as a group discussant at least once over this course. As a peer discussant, we will ask you for one of the 10 sessions to please prepare some questions based on the readings. You can then raise points that inspired you, confused you, or interested you, and we ask you to try to reflect on an example from your own work and how that might relate to the readings. You will have an assigned small group leader co-leading with you, so we are not going to basically leave you to flounder. We will really be supporting you a great deal, but we do ask you to volunteer so that we can make sure that everyone's really getting the most out of this course. And in our experience, the act of leading a discussion really helps to solidify the principles and helps you to really internalize it in a more engaging way than being a passive recipient. Finally, our plea for you is pretty please only sign up for this course if you are committed to attending at least 7 sessions. If you know now that you're going to miss more than 2 sessions, we would ask you to please wait to take this next year. It really does affect our group experience when we have a lot of attrition and when we don't have solid groups week to week. So we ask you to please commit. We also ask you to please try to have a culture of having your camera on whenever possible. It helps us to not feel like we're talking to 100 black boxes when we can actually see faces and make it feel like a true interactive discussion. And we ask that you please not share the syllabus to this course without letting us know first so that we can be appropriately documenting the reach of this course. All right, so as promised, that was your first 10 minutes about course logistics. Now let's dive into implementation science. What is it and why and how is it useful? We assigned you a reading called the D&I Bridge. And this is a bridge that we at our Center for Dissemination and Implementation Science use frequently to address the question, what is implementation science? In a nutshell, we define it as bridging the gap between what we know in terms of public health and medical knowledge and what we actually do in terms of public health and medical practice. And we have argued at our center that this is not one simple gap. Well, it's certainly not simple, but nor is it just one. It is really a multitude of gaps that interplay to become this enormous divide between what we know and what we do. And there are 4 in particular that we often talk about in our center. I will get to those 4 gaps in just a moment. First, I do want to acknowledge that this course is called the Implementation Science Reading Course. And we want you to know that dissemination and implementation are slightly different. Dissemination science, so the D in CDIS, our Center for Dissemination and Implementation Science, is really the scientific study of targeted distribution of information and materials. It's basically about spreading knowledge and with the goal of spreading information, with the goal of increasing knowledge and awareness. Implementation research is the study of the use of specific strategies to adopt and integrate evidence-based health interventions into specific settings. In a former life, I was an econ major, and if I put my econ hat on, I like to think of dissemination research as research to increase the demand for effective health services, and implementation research as aimed at increasing the supply. In this course, we're really going to be focusing on the I more than on the D. If we go back to this original slide, we think about the supply gap as the fact that there's not enough interventions, and the demand gap as the fact that once interventions exist, people can't access them, and there isn't enough awareness about them. Both are important, but in this course, we predominantly focus on the I. Why do we do this? Because our healthcare system is extremely fragmented, and we do have some problems on both the supply and demand side. On the supply side, there is a really nice set of reports by the Institute of Medicine that document the enormous chasm between what we know and what we do. It's called Crossing the Quality Chasm series, and it really documents how this gap plagues all of physical and behavioral healthcare. There's a statistic in our field that it takes 17 years to turn only 14% of original research to the benefit of patients. This statistic came out about 28 years ago, but has been replicated across multiple studies. And this 17-year odyssey, where we lose 86% of our research, is because of all the slowness throughout the research cycle. And this fact that we have this leaky pipeline. So throughout the grant review cycle, the publication review cycle, the process of synthesizing research, we tend to lose a lot of our research throughout this pipeline, so that ultimately only a very small fraction actually benefits patients. So our goal in this course is to help you learn methods that can help you to increase both the speed of your research and the amount of your research that is relevant to patients. One of the reasons we have this supply gap is that historically, research has been done in a very sequential and slow manner. So we looked first if there was a relationship between, a specific variable, an independent variable and a dependent variable. Once we had a signal, we would then do a highly controlled efficacy study. And only when we knew something worked under highly controlled circumstances did we see, does this work in the real world? And only then did we think, can I get this out into real world settings to actually help them to deliver it? Our argument is that if you consider implementation from the outset, and right at the beginning, we think about testing our interventions in settings that are like the ones in which they will be delivered. And if we think about accelerating our pipeline right from the beginning, we can address this leaky pipeline, increase the impact of our research, and importantly, increase the speed. The demand gap is important as well. We will not focus on it as much in this course, but we like you to be aware that there is a major one that exists. For any given diagnosis, there tends to be a large unmet need, with a high percentage of Americans that have that diagnosis not receiving any services at all. On your screen now are 3 examples. For any 10 persons with a substance use disorder, only 2 will receive any specialty care. For persons with mental health disorders, out of 10, and only 5 will receive any care at all. And for persons with physical disabilities, historically, only 7 out of 10. So these are large proportions of unmet need. And when we look at this systematically, we see that the level of unmet need tends to be greatest among those with lower education, lower socioeconomic status, and from racial and ethnic minority groups. So there's a huge challenge also in increasing access to care and addressing these demand side barriers. Other gaps, which we won't go into as much depth about today, are what we call expertise and methodological gaps. This is the idea that we don't invest in the right infrastructure to support implementation science research in this country. One example that is salient related to the case that we'll be looking at today, which is an addiction science case, is the fact that we don't fund this type of work nearly on the level that we fund discovery science. So the visual on your screen now is showing a period of 5 years during which the National Institute on Drug Abuse funded in the historic Helping to End Addiction Long-Term Initiative, which was unprecedented investment in addiction research. And less than 2% of all of the research that was funded over that 5-year interval was what we would consider implementation research. So we continue to fund very high levels of discovery science, finding interventions that work, but we spend much less attention and funding and infrastructure thinking about how to actually get those treatments to the people that need them. As mentioned, this course will focus predominantly on the public health supply gap or implementation. We also hope that we will address the scientific and expertise gap by building your capacity to integrate these methods into your research. To bring it all together, building the implementation science bridge can really be thought of as extending the science, the status quo. So the status quo, we tend to think about effective interventions or things, and we look at their effect on patients. And we look at the extent to which it helps patients' symptoms, functioning, and satisfaction. What that ignores is a whole lot of context in terms of the settings where people deliver that intervention, the policies that support that intervention, the extent to which that intervention is acceptable to people. All of those are important factors to consider. For instance, we also need to consider the how. How? What actions are we going to take to help people to deliver that thing? What outcomes are we going to look at that might matter to the people that are delivering this intervention? For instance, is it feasible for them to deliver? Is it acceptable? Is it costly? Can they do it with fidelity? And is it efficient for them? Is it equitable? Is it patient-centered? All of these issues really form the core of implementation research. So now I'm going to turn it over to Dr. Bradley to walk us through some of the key terms in implementation science. And I think we're going to spotlight Dr. Bradley.
Awesome. Thank you, Dr. Becker, for that foundational insight and framing. And I'm going to move us a little further in that framing, but would like to add my welcome to everyone. And we're really glad to have you a part of this community. I think we consider ourselves not just kind of a discipline, but also a group of folks who care about things in the world, care about population health and improving population health, and care about doing that work together, which you will find that implementation is deeply related to collective action and collaborative work. So, a little more with what Sarah has said so well, as she said, with less jargon, some of the things you'll hear, right? You'll hear the innovation referred to as the thing. This is Jeff Curran's language. Implementation, doing the thing. How do we help people do that thing? Effectiveness research is looking at the way that things work, and if they work equitably, improving health. Implementation research is going to be looking at how to help folks do that thing. And the determinants are part of that context, where I often like to say that's where the party is. These are the conditions that we explore that help us understand what makes it harder or easier to get that thing done, to help folks do that. The strategies are the actions that we take to help them do those things. And implementation outcomes are about evaluating how much, how well, or how equitably the intervention is done. So we'll go to the next slide. So this is, we like to just kind of joke with you a bit. Are you taking this all in yet? There's so much to fill you with, but we're going to move a little further and help sort through these ideas a little further. The next slide helps us kind of, and it is the apex of the theme for the title for this session, is about that shift in focus. And for a lot of folks, the transition from efficacy, effectiveness research to implementation research incites a paradigm shift. Intervention research is, we like to describe it as a bit more like portrait mode on your camera, or your phone camera rather. So you're hyper-focused on testing the intervention that's in front of you. The whole delivery system that supports that intervention is, of course, there, but less of a focus. It's more blurred out, right? And that's because the delivery system is, for the most part, in efficacy work, highly controlled and frequently measured. The delivery system is. But a more purist notion of implementation research would be the opposite. It's more like landscape mode. If your phone has that, or which I think most phones do, the thing or the intervention is the blurry part. Your attention turns to all the things that are happening in the background. So that's one of the ways that we use to kind of differentiate and help us know what's happening in implementation research. Next slide, please. I think you had this particular paper by Lane Fall, Bates and colleagues, where they introduce what they call the implementation science subway map, and it's really just a visual and conceptual tool to help us navigate the complexity of and understanding what's happening in implementation research. And the map starts with identifying a practice of interest or an intervention. Rather than assuming the next step, it shows you the possible routes that you can take, right? Such as effectiveness research, how you would get to a hybrid design, and how we want to get to scale up and sustainment. And so along the way, you encounter key decisions. And one of the main contributions of this paper is really that it reframes implementation science less as like a rigid set of stages and more about kind of a science of problem solving, as a problem solving enterprise. And so you are explicit about where you are on the map, and we'll ask you some questions maybe to think about that in your small group. Next slide, please. I have the great joy of sharing in this reading course a value that's deep within the center, and I think IFAM more broadly, the idea of how we pay attention to health equity, and many of you know that in some ways that it's almost a curse word to say, but we are still like we just believe it's intimately and integrally a part of what happens in implementation research, and so this particular work pays attention to healthcare equity within the implementation context. And so our first, and we can click through these, Sarah, if you would like to, that the guiding principle is that racism must be recognized as fundamental cause of health, illness, and health wellness. And then we also think about equitable healthcare requires multi-sector partnerships. So that's a part of the work of implementation science to attend to the issues of healthcare equity. And then we also, as a guiding principle, agree that context is central to healthcare equity. And that's thinking about context and not just this backdrop, right? But thinking about context as interactive, influential, modifying, facilitating, or constraining the work that an intervention does and that implementation. So we're looking at roles, relationships, and interactions. Once again, this focus on the context. And finally, the guidance that equitable healthcare requires active engagement of community members and other relevant partners. And so you're going to see this. You can go to the next slide, Sarah. Absolutely. You're going to see these themes come out in the course as well. Some more notes from the Bauman and Kabasa paper talking about how we center healthcare equity. These key points that we focus on reach from the very beginning, and representativeness in our populations, design and select interventions with and for high disparity populations with implementation in mind, thinking about how that intervention is going to be implemented and executed. Implement what works and strategies that reduce inequities in care is another key emphasis. The science of adaptation figures prominently in implementation research that is centering equity in healthcare. And then lastly, using an equity lens for implementation outcomes. And some people struggle with the language of lens because the idea is that you can take it on or take it off. But I think that is in fact very true, right? That you can choose to see certain challenges and problems with equity as an ultimate goal of the work. And so you can, in fact, choose to put that on. That is a modifiable capacity that we have in our science. Okay, next slide, please. I really enjoy this particular schema that Shelton and colleagues offer, and I think it kind of just very simply shows us these different elements of implementation research with this notion of the lens. We can think about a lens, not just as far as the equity lens, but there are also different theoretical frameworks that help us to see the problems of power or to see the problems of inequality. That helps us to measure what's going on in the social context and relations. And so all of that with that lens, we have an opportunity with implementation research to see the particular components and aspects of implementation research through that particular lens, which is what makes it interdisciplinary. And I think for me, what brings such great excitement and innovation to the work. Next slide. Okay. So we'll conclude. I wanted to draw out even further, right? We've taken you in a little more proximate to some of the concepts. If you think about this now, this slide is more about kind of what some experts and folks who have done the work have thought about more in a kind of a macro way of how the field can respond to equitable implementation science. And there are some who would in fact say, right, that implementation's business is about making sure that people have access to interventions and evidence research knowledge to improve care and outcomes. So in the field, we talk about attention to those multi-sectorial partnerships to promote health equity. We talk about how we handle evidence, questions of whose evidence is it and who's involved in understanding and translating that evidence for different populations and contexts in real world settings. We think about also in a more kind of global level how we want to focus on policy development, the translation of these evidences into policies. We want to be agile, be responsive and adaptive in our use of frameworks. So we'll spend some time even in this course talking about theories and frameworks and paying attention to the limitations and the capacities that they offer to our science. Identify and redefine those metrics. So we talked a little bit about those outcomes. And thinking about the diverse stakeholders and partners and the work of dissemination that has to happen that is a part of promoting equity. And finally, this focus on de-implementation, misimplementation, and sustainability are also important concepts within the realm of implementation research that are central to equity.
Thank you so much, Corey. I
Absolutely.
think we're going to switch the spotlight. Thank you so much. So you can all see why I love presenting with Dr. Bradley. I feel like I learn something new every time. And I will say that the portrait mode analogy is one of my all-time favorite metaphors for teaching implementation science. Okay, so one of the things that we really like to emphasize in this course is that your feedback really matters. We have been offering this course for 7 years, and each year at the end, we solicit your feedback about ways that we can improve the offerings. And 2 years ago, we got the suggestion to use a running case example and to really help to build the elements that we teach each session, into one specific cohesive example. We did that last year, and the feedback was very positive, so we are delighted to use that approach again. So we will be using this case example throughout all 9 of your didactic sessions. And it is about screening and brief intervention for risky drinking across 10 pediatric trauma centers located across the United States in 10 disparate health systems. And the process that you see on the right side of the screen is one that we will refer to throughout this course, where we think about implementation science in a really systematic way, where first we need to identify a gap. Then we select the thing that needs to be implemented. Then we use a systematic process of identifying what we will call contextual determinants, or barriers and facilitators for short, or in that slide that Dr. Bradley showed you, the conditions that make it harder or easier to do the thing. We then create some sort of blueprint or logic model. We will actually, in this course, spend quite a bit of time teaching you what we call the implementation logic model. It was created by 3 Northwestern researchers, J.D. Smith, Dennis Lee, and Miriam Rafferty. And we are delighted that Miriam Rafferty is a small group leader this year, and Dr. Lee will be guest lecturing in a future session. After you create a logic model, you evaluate how well or how much your thing was implemented, and then you think about sustainment and maintenance. Actually, I should say, then you measure sustainment and maintenance. You should be thinking about that throughout the whole cycle. So in this case example, there were level 1 pediatric trauma centers across the country that were mandated to provide screening and brief intervention for risky drinking. This was actually a requirement of the American Academy of Surgeons for programs to be certified as level 1 trauma centers. However, in practice, rates of screening and brief intervention were incredibly low. And there was also quite a bit of literature suggesting that screening based on clinical judgment is often racially biased, with some races not getting screened as equitably. So the thing that was selected was screening and brief intervention using a protocol recommended by the National Institute on Alcohol Abuse and Alcoholism. We then assessed barriers and facilitators as a starting point by reviewing literature. And we also surveyed 10 system partners to learn about this. And then we created a blueprint. Over the next few sessions, we will dive into each of those bullets in much greater detail so that you can understand what that process was like of assessing determinants, selecting the thing, and creating the blueprint. We did great on time today. I said we hoped for at least 20 minutes in our discussion group, and we are doing fabulous. Before we go to our discussion group, I just want to note that the goal of your group should really be to reflect on the readings, think about how they relate to your work, and how that work can apply. We often find that in the small discussion groups, people end up asking very specific questions about their own studies and ways that they might be able to get some help or get unstuck with specific problems they are having. You can certainly do that, but I want to note that is not the goal of the small discussion groups. The goal is for everyone in the group, which is about 8 to 10 people on average, to be able to have a shared discussion and learning. So if you find that you have specific questions that you really need answered, we encourage you to request a consult from our team. Through NewCats, you can go to the resource request and registration form. You can Google NewCats Get Help, or you can go to CEDIS's website and click under Training and Services to request a consult. You will see this long menu of consult options, and if you select Request a Dissemination and Implementation Research Consultation, you will be assigned a free consultant from our team that can have a one-on-one methodological consult with you. So please, if you do find that you are struggling based on the readings to really relate things to your own work and you want to take your work to the next level, we encourage you to use this pathway. All right, so we will momentarily be dividing into our 10 to 11 small groups. Some final thoughts. In today's group, we really want you to get to know each other. So we encourage you to introduce yourself to your group members. And when you do, we ask you not only to share your name, your role, and your research, clinical, or policy interests, but we'd also encourage you to reflect on where you currently think your research falls along the implementation science subway. We would like you to take some time today to sign up for the peer discussant role. Your small group leaders should be able to drop that link in the chat during your breakout discussion today. And then, of course, we encourage you to discuss the readings. It really helps us to make sure we address your questions if you let us know burning questions that you might have. So when you're in your small group, please also let your small group leader know if there's any specific questions you have about implementation science that you really hope to get answered by the end of this course. Other than that, please stay tuned for the slides and video recording to be dropped on SharePoint, and we will look forward. That is a mistake in the last bullet. We will see you the same time in 2 weeks, so 2 weeks from today. Okay, so I'm going to turn it over. The wonderful Emma Little will be assigning folks to groups momentarily.